So what is the timeline, what are the dynamics of this condition? So from the time of exposure to when you can detect virus in the blood is about a week at the earliest. The clinical spectrum is variable. Most patients actually are symptomatic. Between 50 and 90% of patients will develop symptoms, usually within 2 to 4 weeks after the exposure. In one cohort where they actually followed, retrospectively went back and asked these individuals, the majority actually did seek medical attention during this syndrome, but most of them were not diagnosed. So it's a missed opportunity to really intervene early. And this is generally the case for most patients. Therefore, to diagnose HIV at this acute phase, we have to be able to think about it in our differential. And since, the rules are there to screen everybody, and emergency rooms are the front lines for that, just screen, just follow the guidelines, and you may be able to pick some of these cases up. Now, the clinical manifestations are essentially similar to what we call with the acute Epstein-Barr virus, but I'll tell you some unique distinctions. We describe it as a mononucleosis-like syndrome or a really bad flu. There's fever, there are swollen glands, lymphadenopathy, pharyngitis can be present, a rash, mucocutaneous ulcers can be a very important sign, myalgias, arthralgias, fatigue, and diarrhea. So nothing very specific, but it should be something that you would think about, especially if the symptoms are prolonged. So if you have a young person with fever and unexplained symptoms that last more than 3 days, especially if they have a risk factor like an MSM, really think about acute HIV. So how do we distinguish it clinically from Epstein-Barr? Well, pharyngeal exudate is less common with acute HIV. The rash may be more common with acute HIV. It's a generalized erythematous, non-paretic, maculopapular rash. I'll show you some pictures of it on the face and the trunk, sometimes on the palms and the soles. It could be difficult to see in darker skinned individuals. Aphthous ulcers in the mouth would be more common with HIV than you would see with Epstein-Barr. Mucocutaneous ulcers in the mouth, esophagus, or genitals. It's less likely to have enlarged tonsils with HIV than with Epstein-Barr. Splenomegaly, again, more common with Epstein-Barr. Diarrhea and myalgias may be more likely with HIV. Less increase in transaminase, so if you have really robust transaminitis, may be more likely to be Epstein-Barr, even with jaundice. Aseptic meningitis we could see with acute HIV, including facial palsies and Guillain-Barré syndrome. And as I mentioned, the CD4 count could dip down to the point where you could even see opportunistic infections. And there have been cases of PCP during the acute retroviral syndrome. But the bottom line is all of this is well and good, but you really need to do the serology to be able to distinguish these syndromes. So what are the most common symptoms? Again, most people are symptomatic. Fever in almost everybody, lethargy, myalgias, the rash, headache, pharyngitis, adenopathy. Not that specific, but these are the syndromes that we want to be thinking about. Here's the rash. It's this maculopapular rash, more on the trunk than the extremities. It can involve the palms and soles. So the major differential would be obviously with secondary syphilis. It can have acneiform rash that can be present as well. And again, it lasts for about 2 to 3 weeks. The swollen nodes can persist much longer than that. And the fatigue, this chronic fatigue, could even persist for longer than that. So our differential includes Epstein-Barr, cytomegalovirus, acute toxoplasmosis, primary herpes simplex, especially with the adenopathy and the fatigue, secondary syphilis, early viral hepatitis, adult still disease, or drug reactions if they were on medication, or even herbals, etc. So we have to really think about it because the diagnosis is so broad, and some patients may not openly report risk behavior that would, think that they're at risk for STDs or HIV. So we could ask specific questions, but patients themselves may not even be aware of the risk, or it might be something that they didn't think about, or it was done something in passing. So the lack of a specific exposure history should not dissuade us from doing the screening for HIV, especially if they have a clinical syndrome that's consistent. So as far as diagnosis, the hallmark is a negative antibody test with a detectable plasma viral load, or a positive screening test with a negative confirmatory test. That's the time when we want to think about acute retroviral syndrome. If you do a testing of the viral load, we're not expecting it to be, 300, 400. It's going to be extremely high in the hundreds of thousands or higher. So again, a Western blot, which we consider the definitive test, as I'll show you, requires 2 different antibody bands. So when Western blot means you're going to be testing antibodies against different parts of the virus. So there have to be a series of different antibody bands that are detectable in this gel. And you have to have at least 2 of the ones that are there, a band, an antibody to P24, GP41, or the GP120, 160. If there's a single band at GP120, 160, that's sometimes suggestive of an acute retroviral syndrome. So that wouldn't be a positive Western blot, but that might be a suggestive sign that they could be in the early stage of infection. This is the timeline. After exposure, the first thing that will come up is the RNA. We usually can't detect that because we're not, there is only one test that's approved for screening with RNA, and it's usually just not readily available. Then the symptoms come in. Then you start to measure P24 antigen, okay? And then the antibody, the third, second, and first generation testing. When we talk about second generation antibodies, that was just the IgG, and it takes a few weeks to develop IgG. The third or newer generation antibody test also screens for IgM, which can be positive in the first couple of weeks. And then we can move on to where the confirmatory test. So this is the evolution of a Western blot. So in the first week or so, you don't have any of these bands. And then up to day 30, you start to pick up these bands, and you're more likely to get a positive test. So this is really a delay in our ability to diagnose. And it hampers our ability to diagnose acute HIV if you have to wait for this Western blot. Now, if patients are just not presenting clinically, then why do we need a more accurate test? And as I'll show you later, and especially with that ER study, patients are presenting during the acute phase of the infection. And you could miss them if you get a positive ELISA and wait and have a negative Western blot. That could be read as a negative test, and that will defer the ability to diagnose these persons. So again, as far as our diagnostic issues, the infection comes, the RNA comes up first, P24 antigen, then we start to see antibody. Our new tests can pick up the antibody, within the first 4 weeks or so. The second generation, which is most of the oral rapid tests that we do, are only second generation tests. So we're going to miss some of the acute infections if we just rely on those rapid tests. And then, so this would be our standard testing if we're just using a rapid screening test. If we use a 4th generation, the antigen antibody can really shrink that timeline down. And for now, that's the best that we can do unless we do what we call the RNA screening. So the Western blot is way out there. This is our rapid test, the OraQuick 2nd generation test. Then we get into where we see our antigen antibody combo test, which is way over here. So the new algorithm will be using this architect or a similar antigen antibody combo test, which really shortens the timeline to diagnosis. And then the Aptima, which is a qualitative RNA test, plus or minus, is the only approved test measuring virus directly for screening, for diagnosis purposes. You could do a viral load. It's not an approved test, but the Aptima would be the one that's approved. So this is the new algorithm that's going to be revealed on June 24th, June 27th. It's been kicked around and discussed, so it'll move from proposed to the actual testing algorithm. So this is how we're going to be doing screening once the labs start to adapt it. So you do your initial testing with a 4th generation immunoassay, which are more sensitive than the old IFA tests that were done before. A rapid 4th generation is coming, but usually it can be done within an hour. You'll get the result, 20 minutes to an hour. It'll be negative, and you could stop at that point. If the person has a clinical syndrome highly suggestive of acute HIV, then you could do the RNA testing if you're really suspicious for acute infection. If it's positive, then you could have either antigen or antibody, and then you have to do a differential immunoassay. That will immediately tell you, are there antibodies to HIV-1, HIV-2, or both? So if it's HIV-1 positive, then you would measure the viral load, link them into care. HIV-2 positive and HIV-1 negative, then you can send them to care and we'll figure it out and we'll treat them. There's no viral load that's available for HIV-2. If they're both positive, then additional testing will be needed. Again, send them to Spencer Cox or to your local HIV expert, and they will be able to distinguish and manage these patients with additional testing. Now, if they're positive on the screening test but negative on the differential test for HIV-1/2, that's when you do your RNA measurement. If it's negative, then we know they're not having acute HIV infection, because remember, that viral load should be in the hundreds of thousands or higher. If it's positive, then we know they're in the acute phase of the infection because they had a 4th generation positive, the immunoassay is negative, and they're RNA positive, and that's your acute infection. This is the most important test is this HIV-1/2 differentiation assay. It's a rapid test, 15-minute turnaround. So now, instead of having to wait for that Western blot to come back, while they're in the ER, you can do the screening test. If it's positive, you set up on the same sample this differentiation test in 15 minutes. The result will be available, and it can distinguish are they HIV-1 or HIV-2 positive. And if they're negative on this, then you have to draw a blood test to do an RNA. You can't reflex it. It actually requires a separate stick for that. Okay? So how does it perform? So there was a large study done in New York City, San Francisco, North Carolina, of high-risk people at STD clinics, at partners of HIV-infected persons, and they screened 37,000 individuals. They found 654 positive on antigen or antibody testing, and they did the differentiation assay, so this was a test of the new algorithm. They found that 85% of them were HIV-1 positive, none were HIV-2 exclusively positive. They had one person who was both 1 and 2 positive, who went on to additional testing. And then you got this group here, which might be acute infection people. They're HIV-1 and HIV-2 negative, but they were positive on the 4th generation test. They got RNA testing, and 55 or 56% of them were RNA positive. So these were acutely infected individuals. And Western blot was only positive in 26% of them. So this is an assay where these individuals might have been missed if you did not adopt this current strategy, which is now going to be the official way we're going to be doing HIV testing going forward. So the importance of this new strategy is we can really identify these very early people with very early infection. And you can give an answer to a person right then and there. You don't have to have them come back and wait for the Western blot, and this, you tested positive in the ELISA, we have to wait for the Western blot, which is obviously a very difficult time for people waiting to get that information. Now, our patient was pregnant, so the symptoms could be attributable to other things, URIs, etc., of an acute retroviral syndrome. It could occur anytime during pregnancy, even after their initial screening is positive. So this is one of the issues for residual mother-to-child transmission, where a person screened negative and they didn't get that 3rd trimester screening, which is required. And of course, this is a time of very high risk of mother-to-child transmission because the viral load is so high in the maternal blood. So we've reduced our risk of transmission mother-to-child of HIV from about 18% down to 1.5%. And it's been fairly stable in that range for a number of years in New York State. The residual transmissions are due to women who are aware of their infection but are not linked into care, or these acute seroconversions. So it's really important that we recognize these cases during pregnancy. So there is a requirement that a second test be done in the 3rd trimester to try to pick them up. But if a woman comes in with syndrome of acute retrovirus, we would want to recognize that as soon as possible. The proportion of transmission in utero has now gone up. It used to be 27% of the cases had in utero transmission, and most were transmitted in the peripartum period, rupture of membranes, etc. Now 80% of the transmissions are in utero. So what's going on?